start the decision with the presence of Dr. Farouk Shahid from United Kingdom. She is a consultant pathologist and honorary lecturer at University College of London. Will talk about updates in iron pollution.
Hello, thank you all for inviting me. It's my great pleasure to come to Cairo, and this is my second year Professor Bishlawi has invited me in a row. I'm very honoured. I'm going to be covering iron chelation therapy and just basically giving you a rundown of the publications that have happened in the last 12 months to 2 years or thereabouts. There's been a lot of new literature on thalassemia major and iron overload. So the plan today, this morning, is to talk about chelation options, and I'll be talking very quickly about desferal, but also in a bit more detail around deferocyrox and deferochrome, and the new oral iron chelator FSB0701. And I'm also going to talk a bit about using these drugs in combination. And then finally, I'm going to just present a little bit of data from the red cell disorders unit, which is University College Hospital and Whittington Hospital as a combined unit, and the impact of the way we practice chelation therapy and its impact on survival in our patient population. So, chelation options. There's been a real increase in publications over the last decade or so in iron chelation. Initially, the main publications, of course, in the 1960s were on desferrioxamine and its use both as a chemical agent and also its impact in a clinical trial in 1974 showing improved survival. And then there was data in the mid-1980s on the use of desferrioxamine intravenously in patients, and then deferochrome came on the horizon in the early 1990s. And then there was, of course, an increase in publications numbering about 100 a year for that preceding decade. And then deferocyrox came onto the horizon, and in about 2000 we had preclinical data being published, and then deferocyrox in clinical data being published. And as you can see, there's been an almost exponential increase in the publications in the last decade on iron chelation therapy. And in general, these publications have been focusing on the control of transfusional iron overload in various conditions, so thalassemia, sickle cell disease, myelodysplasia, and the rare anemias. And then also, more importantly, I think, for Egypt in particular, the control of non-transfusional iron overload, so the non-transfusion dependent thalassemias. There's also been some really interesting data on improvement on hematological function, bone marrow function in patients with myelodysplasia, and that data, I think, really needs some further investigation. And also some very interesting data on the use of deferochrome in patients with Friedreich's ataxia and other conditions where there is a maldistribution of iron. And then, of course, new chelators with new chelation regimes, particularly the combination regimes. So desferal monotherapy, this is such an old drug, we all know its impact on survival, and the most recent data was published in 2004 looking at the Italian registry and showing again that in the birth cohort, which has the best therapy available from the start, that's the 1985 and onwards birth cohort, survival is virtually 100%. And clearly in the older cohorts, which weren't chelated at a young age, survival has fallen off over the years. So good chelation with desferrioxamine from the very beginning does impact on patient survival and clinical outcomes. And the newer chelator, deferocyrox, we're going to talk quite a bit about deferocyrox because there's been a lot of very interesting data on deferocyrox, both on its impact on myocardial iron, but also on its longer-term safety data. So this graph shows the phase 2 and phase 3 clinical studies with deferocyrox. And the first line that you're seeing is the changes in dosage over time with deferocyrox. And in the clinical studies, you can see that we were dose restricted. We could only use a 20 milligram per kilogram per day dose. But once the initial trial phase was over and people went into the extension phase, the doses were escalated for therapeutic benefit. And the blue line shows the impact on the serum ferritin, so a very considerable improvement in overall iron burden with the use of the ferrosirox with increasing doses. Now, the other important long-term safety data is the fact that the side effects that were encountered to a large extent in the first year, the high serum creatinines, the abdominal pain, nausea, the rash, vomiting, all of those side effects were significantly reduced over the 5 years that these patients were followed. So, using the ferrosirox over a prolonged period of time, the side effects do go away and patients do adjust to those side effects. So it's worth persevering. And this is really important data. This shows basically the impact on the serum creatinine on patients over the 5 years. And what you can see is that in the extension phase, it generally remains stable, and over 5 years, again, the serum creatinines have essentially remained stable. Now, this graph, I think, has been shown quite a lot in the last year because I think it gives very, very useful information from the EPIC trial and was published by Professor Pennell in late 2011, early 2012. And certainly I've been using this graph since the data became available. What you can see here is the green line is all patients that were enrolled into this section of the study, which was patients who had myocardial iron loading. And this is the patients with severe, and this is the patients with mild to moderate iron loading. And what you can see is consistent improvement across all groups in iron overload in the heart. The T2 star steadily improves, and in patients with mild to moderate, they actually successfully clear their myocardial iron at the end of 3 years. So it's worth persevering if you are seeing on serial scans that things are improving. There is, of course, another study that's currently ongoing. It's the Cordelia study, which is a randomized controlled trial of the ferrosirox versus desferrioxamine in patients who have myocardial iron loading. So the recruitment criteria is that these patients have to have a T2 star of less than 20 milliseconds, an ejection fraction more than 56% to enroll. The data for this study should hopefully at least be some preliminary data by the end of this year, and we should have the study available in its entirety, hopefully, by the end of next year. This is, I'm fairly sure, going to provide some very, very interesting data in these patients. There is, of course, another study that is being run at the moment called the Hyperion study, which is looking at combination therapy with Desferal and XJ in patients. And again, we should have some preliminary data for that study by ASH this year. Now, Dujanier from basically published in the Gastroenterology Journal some really interesting data from the original cohorts of patients with thalassemia who were recruited into the phase 2 trial, phase 2 and phase 3 trials. And he looked at the fibrosis scores in those patients for both the people who had a falling liver iron, which is the middle group, so the people whose iron burden improved, and also the people whose iron burden didn't improve. And what's really interesting is that the ferrosirox appears to improve the fibrosis score in the majority of patients. So in about 82% of patients overall, regardless of whether they were responders or non-responders from the liver iron perspective, their fibrosis score actually improved. So it certainly appears that the ferrosirox may be having an effect in improving liver baseline fibrosis levels. And ferrochrome, well, we know that the ferrochrome is a very useful agent in myocardial iron loading, and there has obviously been data that's been published and shown very clearly to show improvement in both T2 star and ejection fraction. As you can see from here, Tanner et al. Showed an improvement in myocardial T2 star with monotherapy of the ferrochrome, and also an improvement in injection fraction in patients on monotherapy with the ferrochrome. But there's been some really interesting data published by both Limenta et al. And also Aginok and her group in Turkey, So first of all, Lamenta et al. This is just old graphs that we're all very familiar with. This is the ferrochrome in its non-glucuronidal form and in its glucuronidal form. But what Lamenta has shown is that patients who've been splenectomized seem to have a much higher ferrochrome iron chelate complex, which suggests that splenectomized patients actually respond better to ferrochrome therapy. And when he then plotted the area under the curve, which is basically the iron chelate complex with the ferrochrome against the urinary iron excretion, what you can see is that in the splenectomized patients there was a very significant evidence of increasing urinary iron excretion and actually reducing iron levels in those patients. Now, Adenoch et al. Did a study in about 32 patients where she gave a proportion of patients to ferrochrome monotherapy and another proportion of patients combination therapy with desferrioxamine and the ferrochrome. And the data is really quite surprising because we certainly weren't expecting that the NTBI would go up at the end of the week. But the NTBI, regardless of whether the patient was on monotherapy or dual therapy, the NTBI went up in the majority of the patients. And the NTBI increased, and the change in the NTBI when it was plotted against the baseline liver iron concentration again showed a consistent, across both groups of patients, a consistent increase. And the NTBI, when you plotted it against the transfusional iron loading rate, again showed a consistent increase. So it increased in all three groups. Now, that's quite interesting. What does it actually mean? Well, it probably means that the NTBI increments that were actually identified were reflecting chelatable iron, which was derived from both liver stores and from red cell metabolism. And that is quite interesting because it suggests that when you give patients to ferrochrome, you actually make available more iron that is able to bind to the iron chelator. And at the end of a week, the change in the NTBI correlated with the plasma ferrochrome iron complex and the urinary iron excretion. So here's the change in NTBI plotted against the ferrochrome iron complex, and what you can see is that the NTBI correlates very nicely with the ferrochrome iron complex. So it is more iron being available to the ferrochrome complex. And the urinary iron excretion, again, correlates very nicely with the chelated complex, with the NTBI. So that's quite interesting data. So it suggests that we should be probably using drugs like ferrochrome in patients who want to chelate iron rapidly from, because it appears to be making iron more available. And I think this goes back to the shuttle effect that we've spoken about for many years. Now, FSBO 701, probably not very many people are aware of this new oral iron chelator. It's basically a derivative of diferrothiazine, which is, many people may know that as the Bergeron chelator. This is a tridentate class of chelators, and renal toxicity in the Bergeron chelator is a class effect. But it has been shown to be minimized by adjustments made in the molecule, and numerous analogues were synthesized, and in fact, one of them actually made it into preclinical studies. That chelator that made it into preclinical studies was called deferritrin, and it was preclinical workup was done by Genzyme, which was the company that was doing it. And unfortunately, they found in the preclinical workup and in the human studies that it was nephrotoxic. However, a very clever person found that by replacing this hydroxyl group in the deferritrin molecule with 369 trioxyadecycloxy group, the nephrotoxicity could actually be controlled. And in fact, what's really interesting about this chelator is that it's associated with very little by way of side effects. So clinical trials with this chelator, currently phase 1b is a published study, and there's also a phase 2 24-week study which I'll show you some data on. The phase 1b study was looking at safety, tolerability and pharmacokinetics. It was in 16 adult patients with transfusional iron overload. And they were given once daily for 7 days doses of FSBO 701 with a maximum dose of 32 milligrams per kilogram per day. Now this has now been escalated up to much higher doses, and what we found was that it was very well tolerated at all dose levels. The pharmacokinetics were dose proportional, and the drug has a long half-life. So it went on to phase 2 studies, and we've been involved in the phase 2 studies in London at the Red Cell Disorders Unit. And there were 51 patients that were recruited into this phase 2 study, and they used 2 doses, 14.5 milligrams per kilogram per day and 29 milligrams per kilogram per day. Nearly all the patients actually completed the study. There was no adverse events, and there was no dose-related adverse events. The commonest adverse event was a mild increase in the transaminases, and it was very mild in about 16% of patients. The mean serum creatinine actually didn't change at all, which is very good considering that the base drug is supposed to be nephrotoxic. The change in liver iron at the 14.5 milligrams per kilogram dose was actually a net increase of 3.1 milligrams per gram dry weight on a Thalassemia liver iron assessment. However, about 30% of patients did have a fall in the liver iron. And in the higher dose group at 29 milligrams per kilogram per day, the overall values were stable at minus 0.3 milligrams per gram dry weight, but 44% of patients actually achieved a decrease in the liver iron concentration, and in some of those patients, the decrease in liver iron was actually very significant. So a promising euthylator, it really is associated with very, very little by way of oral side effects, so nausea, vomiting, diarrhea. Those kind of side effects are actually virtually non-existent in our population that we've been looking at so far. So now on to the newer stuff, particularly the information on combination therapy. So there's been some data published by Pantalone et al., and they've looked at, retrospectively analysed 213 patients with thalassemia. And they were using deferriprone, 75 milligrams per kilogram per day, 4 days a week, and desferal, 50 milligrams per kilogram per day for 3 days in the week. And they compared it to the patients who were receiving deferriprone monotherapy with just 75 milligrams per kilogram per day over a 5-year follow-up. And of course, what you can see is that in the sequential group, the liver iron is actually brought down quite rapidly and then controlled. This is just a measure of the serum ferritin, but the overall iron burden falls quite significantly and is then held at stable levels with a sequential regime. What's quite interesting is that they didn't have any significant adverse events associated with sequential regimes, and there is an argument to be made for using sequential regimes in people who particularly have got side effects related to deferriprone. Now, desferal with deferricyrox. Rob Grady in New York has actually done an iron balance study in 6 thalassemia major patients, and they were given a 34-day metabolic iron balance study. Each patient was his or her own control, and they followed a fixed diet which was low in iron to make sure that there was no other intervening problems with dietary iron. In these patients, they received desferal, 40 milligrams per kilogram per day on days 5 to 10, 8 hours subcut, and then they had a 5-day washout, and then they were given deferricyrox on days 15 to 20, 30 minutes prior to breakfast, and again they were washed out for 5 days. And then on the 25th to the 30th day, they were actually given both drugs together. In the combination cohort of patients, the mean iron balance was minus 251%, which is very significant. In a number of patients, in 2 patients, the effect was actually more than additive, so it was much more than an additive effect. In 3 patients, it was an additive effect, and in 1 patient, it was less than an additive effect. So good evidence to suggest that using combination therapy with deferricyrox and desferrioxime may put patients into a much more important and higher value of negative iron balance than monotherapy with either drug alone. There was another published study which is being presented at ASH 2010, which was looking at Deferoxyrox with desferrioxamine in combination, and it's the US 24T clinical trial. Small number of patients, 15 patients were enrolled and randomized into 3 groups. Group A with severe iron loading, Group A with mild iron loading, Group B with severe iron loading, Group C with not very significant iron loading. And they were given 52 weeks worth of combination therapy using Deferoxyrox 20 to 30 milligrams per kilogram per day, and desferrioxamine 35 to 50 milligrams per kilogram per day for between 3 and 7 days a week. And of course, as you would expect, particularly in light of Bob Brady's study, liver iron came down significantly in the combination therapy group. The serum ferritin fell significantly, and the NTBI also improved. And the T2 stars at baseline improved by about 2.5 milliseconds. Ejection fraction improved by an average about 3 to 4 percent, and the labile plasma iron reduced significantly in combination therapy with Deferoxyrox and desferrioxamine. And then onto the dual oral chelation regime, which is deferriprone with Deferoxyrox. And this data, I think, needs to be looked at very carefully, and I'm sure will need to be repeated in a larger group of patients. So Farmaki published last year a study where he looked at 16 patients with thalassemia major, all above the age of 20, who either couldn't take desferrioxamine or found desferrioxamine inconvenient. And the entry criteria was a ferritin of above 500 micrograms per litre, and the patient should have to go into the study at least one iron overload associated complication. They were given Deferoxyrox at 20 to 25 milligrams per kilogram per day, and deferriprone at 75 to 100 milligrams per kilogram per day. And he found reversal of cardiac dysfunction in 2 out of 4 patients. The ejection fraction increased significantly in all the patients. Glucose tolerance test improved in 2 out of 8 patients with impaired glucose tolerance, and there was improvement in gonadal function. And Farmaki found no side effects whatsoever with any of the drugs. So no rise in serum creatinine, no granulocytosis, no thrombocytopenia, and very mild GI disturbance. And this is the group before, and this is the group after. So if you look at the mean serum ferritin in the entire population, they were all below 1,000. But the ferritin at the end of the study was 103, which is great from my point of view. Cardiac T2 star was very good, both before and at end of study, and the ejection fraction, as you can see, improved considerably. I definitely think this study needs to be repeated in a larger group of patients. It is very, very interesting data, and if this data holds true for patients with higher iron burdens, then I think we may be on to some very significant advances. So what is the impact on survival of managing cardiac iron? So we have been very fortunate in that we were centres that were involved with Professor Pennell's initial cardiac T2 star assessments, and in fact virtually all of the patients at UCLH and Whittington were scanned in about 1999. Patients then obviously subsequently moved on, and so we don't have complete follow-up for the full decade for all of the patients, but 109 of these patients were available for long-term CMR follow-up. The average follow-up was 9.2 years, with a minimum interval of 7 years between scans, and a roughly equal proportion of males and females. Now this is Bernadette Modell's original data, so the first 5 to 6 bar plots are Bernadette Modell's UK Thalassemia Registry data, showing the impact of iron overload on survival in patients. And as you can see, patients were mainly dying from iron overload-related complications, and these iron overload-related complications were heart failure in the vast majority of patients. In this cohort, the predominant cause of death was actually infection and hepatitis C, and no deaths because of iron overload-associated complications. And what you can see in the decade of follow-up with T2 star assessments is a significant reduction in the patients with iron in the heart. So the T2 star improved both in the mild to moderate range and in the severe range. And in fact, fact, it is a bit of a challenge for us now to recruit patients into clinical trials that require patients to be myocardially iron loaded. We don't have those patients, or very, very few of them now. And the causes of death in our population, well, T2 stars, more than 23 patients died of hepatitis C associated complications, and there was one sudden adult death, all still not sure. T2 stars between 10 and 20 milliseconds, one patient died with meningitis, another patient with breast cancer. And a T2 star of less than 10, two patients died because of septicemia, and those septicemias were in fact Klebsiella and Pseudomonas gram-negative infections are the predominant infections that we see in this population. And chelation regimes at the time of death, you can see that patients were on a wide variety of regimes. So no clear relationship with individual chelation regimes. And what you can see is the fact that chelation regimes at baseline were predominantly desferrioxamine based, with a proportion of patients on deferriprone and combination therapy. And then in this decade, in the 2000 to 2010 group, deferriprone actually came onto the horizon, and the chelation regimes have evened out, so that you've got virtually 25% of patients on one or the other of the particular regimes. This is just data from the Whittington site, because we've had FerriScan available at the Whittington site since 2007. FerriScan measures liver iron in a very accurate way using an R2 technology, and can measure liver ions down to really quite low iron levels. Liver ions as low as completely in the normal range. We've, for a period of time, been concerned about the discrepancy between the T2 star liver iron and the FerriScan liver iron. In fact, if you look at this patient, T2 star of about 7, which is in the normal or acceptable range for liver iron, if you look at the FerriScan liver iron, the liver iron was 20. So you would have actually changed therapy if the liver iron was 20, where you might not have been too aggressive with changes in therapy with a liver iron of 7. So that kind of a discrepancy caused concern. And we therefore carried out an audit of our patients, which was presented at BSH this year. And 94 patients with at least 2 scans between January 2008 and December 2011. And what you can see is that from the initial scan to the final scan, there is a significant improvement in the patient's liver iron burdens. So 74% of patients have now got liver ions of less than 7, and in fact, the patients with mild to moderate ranges of iron, liver ions between 7 and 15, even their ions have improved, and patients with liver ions above 15, 50% reduction in people with severe iron overload. Whoops, I'm sorry, it's gone to Arabic again. What you can see here is that the chelation regimes for patients at initial scan and chelation regimes for patients at the final scan. The patients who were on deferriprone monotherapy have either switched over to deferrothyrox or switched over to combination therapy, dependent on patient preference. So, just to conclude, we are in an extremely fortunate era. I think our patients have a real fantastic opportunity to improve their iron burdens, and that is purely because of the availability of 3 separate clinical iron chelators that are validated and well recognized to have efficacy. And we now also have different chelation regimes in combination that are beginning to be published, and data is coming out showing improvement in iron burden with those regimes, whichever regimes those might be. And there's also a new chelator on the block which is looking extremely promising, with very little by way of side effects, and hopefully will give good therapeutic responses. It's very important that you tailor the management of iron overload with the new chelators, and you adjust to the individual patient so that the patient is compliant to their therapy. You do not get good results with iron chelation if the patient refuses or doesn't take the drug properly. And appropriate and regular monitoring has a very significant impact on survival and clinical outcomes in patients. And I'd like to thank you all for listening.
Thank you very much, Dr. Khalid, for this very interesting overview. you for over iron chelation. I think we'll leave the discussion to the end of the session. If I may call on Professor Dr. Amal Ishlawi, our mentor and our leader. Dr. Ishlawi will talk about radiation therapy. It's the way of prevention and management of thalassemia complications.
Thank you very much for the chairman, Professor Dr. Nordin Adah, Dr. Amona Taghi, she's sitting in front of the board. Thank you very much. Now I will call about, I'm going to present radiation therapy and its way of prevention and management of thalassemia complications. I'm going to talk about thalassemia overview, iron overload and iron toxicity, iron chelation therapy, and my conclusion. As you know, first slide usually is thalassemia in Egypt. Thalassemia in Egypt actually will have a very high carrier rate, which is actually one of the highest carrier rates maybe all over the world. Gene frequency is 0.3, and more than 1,000 is born yearly by thalassemia major. And these are the registered cases up to 2007, is around 10,000, but actually we have, I think, double this number who are not registered. And this shows you the increasing number. This is from our clinic in Abu Dhabi, Cairo University, shows the increasing number of thalassemia cases all over the year, started from 1998, 1982, up to 2011. We have around 3,000 patients with thalassemia major, and actually this increasing number is due to the lack of prevention program, national prevention program in our country, though it already started years ago in other Arab countries and of course in European countries years ago. As all of us know that the main treatment of thalassemia, or the cornerstones of thalassemia treatment, are red cell transfusion and iron chelation. The combination of transfusion and chelation therapy has dramatically extended the life expectancy of thalassemia patients. And this is showing you the Morgan-Pignati curve, which is very famous in every presentation you see, that in the era of dysphoxamine in 1965, there is increase in the survival of the patients. Here is before the era of dysphoxamine, and after the era of dysphoxamine, actually the survival of the thalassemia patients remarkably increased. For transfusion therapy, actually it has benefits and has its hazards. Benefits, has a lot of benefit for the patients to prevent the complications of severe anemia, but at the same time the transfusion therapy has got a burden of iron overload in these patients, except if they are well cleared. So if we give one unit of blood containing 200 milligrams of iron, so when we have 0.4 milligram of iron per kilogram of weight per day, besides the absorption, the increased iron absorption from the gut. So the end result, increase in the iron in the body of these patients, and all of us know that the body cannot get rid of this iron alone. The patient should take iron chelation. The rate of iron loading actually influences the therapeutic. This is shown here, the transfusion iron overload. This is coming from the electron, which is going to be by the metabolism, catabolism of the RBCs, go to the macrophages. The iron will be released, go to transferrin in order to go to be released into the liver parenchyma. If this iron overload increase as well, electron plus transfusion, and now the transferrin is fully saturated, what will be? Non-transferrin bound iron will be in the plasma, which can penetrate into the cells and can cause the damage and hazard of the different cells of the body. about the non-transfusion bound iron and the bioplasma iron, this is actually present in the plasma, and this which is actually present inside the cell. It is redox active, it is activatable, and it is capable of permeating into organs and inducing tissue iron overload. Sustained level of the bioplasma iron could over time compromise organ function and patient survival. For iron overload and iron toxicity, once the body has accumulated 12 to 24 grams of iron, there will be significant clinical manifestation of iron toxicity which can be expected. Iron toxicity can occur as early as the age of 2 years of age in beta thalassemia patients regularly transfused. As you all you know, that we have patients who can start transfusion regularly by the age of less than 6 months. This will lead to progressive dysfunction of the heart, liver, and endocrine glands, gross retardation, and delayed onset of puberty. These are the organ systems which are susceptible to all of the load. This given the clinical sequelae of for the pituitary, impaired growth, cardiomyopathy, hepatic cirrhosis, diabetes mellitus, and hypogonadism and infertility. As regards the heart, in many patients, this is a very important point, there is an abnormal function is observed in the absence of any symptoms. Symptoms are observed about 10 years after starting transfusion in unrelated patients. Symptoms may be aggravated by myocarditis and pulmonary hypertension, and as you know, that pulmonary hypertension can be common in patients with thalassemia, especially patients with thalassemia intermediate. Survival is determined actually by the amount of iron loading within the heart. It remains the cardiac disease the commonest cause of death. Transfusion iron overload is the main cause, as you already see. Patients poorly compliant to chelation therapy are prone. Serum ferritin level, if it is about 2500, cardiac arrhythmia, cardiac failure, and sudden death can occur in previously well patients. Cardiac stenosis can be found in children as young as the age of 8 years. And this is actually the paper of Dr. Wood showing that we have to do stutostar, which can show the iron cardiac stenosis among patients with thalassemia as early as the age of 8 years. Some patients have a higher risk for heart disease in this context. Patients on this desflurane, patients, males are more prone than females, high ferritin level, and when there is stutostar less than 20 milliseconds. Because the normal is above 20 milliseconds, if it is below 20 milliseconds, meaning cardiac stenosis. And this is shown before the survival by sex. We see that the females survive more than the males. For the liver, iron-induced liver disease is common cause of death in transfused patients. There is collagen formation and portal fibrosis observed within 2 years of starting transfusion. Cirrhosis may develop within the first decade of life if chelation therapy is not initiated. So we have to initiate chelation therapy as early as the rise of the serum ferritin. Liver disease is aggravated actually by hepatitis C infection, and as you know, there we have a lot of patients with hepatitis C infection among our patients with thalassemia multi-transfused. And this is shown with the molecular level or us, the oxygen species concentration in hepatocytes increases with liver iron concentration. With iron overload and red oxygen radical species, stress results in mitochondrial damage, as you see in this slide. Microscopic level, when normal tissue mechanism is overwhelmed, this is the normal liver, and there is hemosiderin, which is inside the liver cell, which is actually very dangerous and can cause remarkable destruction of the liver cells. And this is by a macroscopic level, can show organ damage and dysfunction of the liver, as you see, macro-nodules and big nodules inside the liver, overwhelmed with iron overload. monthly, and liver iron on biopsy, as you see in this curve. This correlation between the iron and the transfusion duration. With the increase of the transfusion duration, there is increase in the level of iron. And this is showing you the liver enzymes increase with the liver iron concentration values more than 15 to 20 milligram iron per gram dry weight. As Professor Dr. Farah said, it should be, the normal is below 7. If it reaches 15 to 20, this means this is dangerous, not only on the liver and increases the liver enzymes, but also for cardiac affection. And this is showing you the complication of iron overload on the endocrine glands. Iron loading within the pituitary disturbs sexual maturation and approximately 50% of males and females. Early second amenorrhea, despite chelation, diabetes mellitus present in around 5% of patients. Hyperinsulinemia also occurs as iron-induced liver damage progresses. The exocrine pancreas is also affected, resulting in decreased amounts of lipase and trypsin. Osteopenia and osteoporosis is common among thalassemic, especially after the age of 10 years, and especially in patients of thalassemia intermediate. This is showing you a group of our patients with this 25 years retarded growth. This is 8 years. This patient is 5 years. This is the same like the patient is 5 years. Because this patient is actually laden with iron, have got high iron overload, and other patients are well treated. This is the classical anemia patients with very bad chelation and the classical facies of thalassemia. It is very important to assess body iron in order to start treatment, and how much we can start treatment, and how much is the dose we have to start our treatment. Standard measure of body iron, assessment of liver iron concentration. This is an accurate reflection of total body iron burden. Measurement of serum ferritin levels can be in association with transferrin saturation test. This is easy and a thing that is available for most of the labs. Indirect measure of body iron burden. Special measures which are very important is the evaluation of cardiac iron by T2 star and assessment of labile plasma iron, as we already see, which is very important for the tissue damage when it is existing. For the MRI assisted assessment of the liver iron concentration, this assessment iron content throughout the liver. It is on the contrary to the biopsy, are only taking only part of the liver, and actually it is invasive technique, potentially widely available. Pathological status of liver and heart can be assessed in parallel, which is actually important. This is showing you monitoring of liver iron overload by MRI, and this bright one showing you that this is area of liver is remarkably laden with iron and iron affection. For the cardiac iron assessment by MRI, this has got an advantage. This rapidly assesses iron content in the septum of heart, which is very important. Iron levels can be quantified reproducibly. Functional parameters can be examined concurrently. This is very important. The ejection fraction can be measured. Pathological status of liver and heart can be assessed in parallel, as I previously said. Actually, for this to start, the normal match will be about 20 milliseconds. If it is below 20 milliseconds, meaning cardiac hydrosis. Iron storage should be monitored with serum ferritin, this is 3 monthly. MRI of liver are 2 or 3 to start every year from age 10, this is important. Cardiac to start MRI from the age of 10 every 1 to 2 years if the to start is more than 20 milliseconds, meaning there is no cardiac hydrosis at the time, or 6 monthly if it is less than 20 milliseconds. It may be less than that 3 monthly if it is less than 5. This is showing you the overall complications of beta thalassemia major, and showing you the cardiac cirrhosis the cardiac affection, cirrhosis, and endocrine by age. This is showing you that from 5 to 10 years cardiac cirrhosis, in cardiac liver cirrhosis, sorry, for cardiac cirrhosis, this starts to appear from the age of 16 to 24 years, and for endocrine affection, this is the endocrine affection which is present after the age of 16 years and about the age of 25 years, we can have manifestations of endocrine dysfunction. And for cirrhosis, it starts early, between 0 and 15 years, in 20 or 16, as you see, all over the age groups, there is cardiac, there is liver cirrhosis. As Professor Dr. Farah said, the causes of death, the main cause of death, this is in Italy, this is a cardiac affection. Actually, it is the main cause of death on all these countries. Italy, Hong Kong, Cyprus, and actually in Egypt as well. Other causes may be infections, and this usually in the age, maybe bone marrow transplantation if it doesn't succeed, accident, and liver affection. For iron chelation therapy, this is as you know, as Professor Dr. Farah presented, the first iron chelator was the Thalassemia. Though it has a well-established impact on survival, as I show you, inconvenient mode of administration, and all of you see, this renders these patients are very bad compliant to this type of treatment. Besides, its complications, as you see, the auditory, visual toxicity, and gross affection. So, the era of oral antichelator started since difenoprone started to exist since the 90s. The difenoprone was the first oral antichelator. This is second-line therapy. It binds 3 to 1. Oral administration half-life is only 2 to 3 hours. This is mainly urinary excretion. That's why most of the patients come in saying that when they take difenoprone, they have got a very deep colored urine. On the contrary of this Xerox, which is excreted through the intestine, this manifestation doesn't appear. Daily inhalation required. This is taken 3 times per day, 75 milligrams per kilogram per day, but in non-responding patients, we may raise this 75 milligrams up to 100 milligrams per kilogram per day, but that you have to monitor these patients for total electricity count and gram electricity count, and in order for other organ affection. As Dr. Farah said, the combined therapy. This is our experience with iron chelation combined hormonotherapy, which has been published in Annals of Rheumatology in 2008, which showed that the combination of difenoprone with bisphenoxamine gives a better result than giving either alone. For Xerox or XJ, it is iron chelator, oral iron chelator. It is dispersible tablets, as you see. They are administered once daily, highly specific for iron. Chelation iron excreted mainly in the feces, 10% only in the urine. That's why you don't see the discolored urine when this patient takes this type of chelation. For the dosing, it is taken once, as I said before. The dose is 20 to 40 milligrams per kilogram per day on an empty stomach. Actually, I'm saying 20 to 40 milligrams, depending on the level of serum ferritin and the response of the serum ferritin and other organs to the level of the medication we are giving. At least 30 minutes before food. This can be given before breakfast or even before at night before for dinner. Preferably at the same time. Whenever you give it in the morning, it should be every day in the morning. In the afternoon, it should be every day in the afternoon. The tablets are dispersed by stirring in a glass of water, as you already see, or orange juice, until a fine suspension is obtained. The tablets must not be chewed or swallowed at all. This is the big study which has been done in 26 countries for XJ. There was a big center in Cairo University and in Nanchang University participating in this trial. And one of the important things which characterize FGA or dysphosphonates that it chelation coverage achievement in other patients for multiple exchange dosing is covering all over the 24 hours. And this is actually important for the white plasma iron when it is present existed. When there is a chelation, this will vanish or decrease this level of plasma, white plasma iron, which is hazard for the cell tissues. And this is one of the advantages of this pharmaceuticals actually and the use of this type of chelation. This is shown that only in the existence of chelation we can find that the white plasma iron decreases. Here this phosphoxamine when it is given, and here when we give difenoprone, it decreases, but increases when we are not giving difenoprone, and it decreases again, and so on. For the difenoprone therapy, it uses dose-dependent changes in iron burden. As I said before, when you give small dose, this may not be responding. But if we increase the dose, this may be responding. The patient may not respond to small dose because he is in need for more and more increase in the dose of this patient. So don't fix the dose for the patient, only follow up the patient and increase the dose. As I said, the dose started from 20 to 40 milligrams. We can increase the dose until the patient is responding. This is shown that increasing the dose, this was the study over 3 years, shows that increasing the dose will decrease the level of serum ferritin over 3 years. This is showing you the reduction of liver iron concentration in patients receiving this pharmaceuticals in a dose of 30 milligrams per kilogram per day, and even the patient has got hepatitis C. This is the starting level of LRC, 16.2, and this is after 1 year of this pharmaceuticals. It is LRC is 30, it is 3 milligrams iron per gram dry weight. This is showing you the dysphoxamine level. It is nearly comparable between the two. This is showing you the liver iron concentration over 5 years. This is showing you that there is significant decrease in the liver iron concentration with all over the year, with increasing the dose accordingly and follow-up of this patient. And this is showing you a decrease in serum ferritin with increase in the dosage of this pharmaceuticals or XJ. So increasing the dose of this pharmaceuticals will increase, will decrease the level of serum ferritin. And this is Dr. Farah showed this slide actually, which shows that to start over 2 years in patients with beta thalassemia on difenoprone, there is increase. This is meaning improvement. This starts with 11 and ends by 15.7, and as I said, these cases start by 7.3. This is the medium one, 7.3, and ends by 9.5, meaning that there is increase in the fetal start, meaning increasing in the cardiac condition. And this is shown with the left ventricular ejection fraction over 1 year. It is the same nearly, meaning that it can maintain the liver, the left ventricular ejection fraction all over its use. This is showing the compliance. The compliance of the patient to this pharmaceuticals actually is very good. This is actually showing you that this is with this pharmaceuticals that the patient, the compliant one is only 48%. If you look here, you find that the compliance is around 86% with this pharmaceuticals. This is the same as well for difenoprone. The compliance is better than much better than with this pharmaceuticals. And this is one of our cases which I would like to present to you, who started this pharmaceuticals and was followed up in our clinic, but lately. She's a female, 23 years old. The diagnosis was beta thalassemia major at the age of 1 year. She received regular transfusion. At the age of 8 years, she developed hepatitis C virus positive. At the age of 10 years, she did splenectomy, and she developed diabetes mellitus at the age of 15 years. Actually, she developed all the manifestations and complications of iron overload. By the age of 10 years, she started this fluoxetine. But actually, she was very bad compliance for 6 years. She shifted to difluridone, but actually she has got already an elevated liver iron enzyme. The liver iron enzyme remarkably some increase in its level. And this patient was enrolled in one of the international studies for this drugs. At the time when she was enrolled, the serum ferritin was 11,272. Tutostar was 13.6 millisecond, below 20. LIC was 24, more than 7 remarkably. And the left ventricular ejection fraction was 63%. This patient was for 2 arms, one arm for bisphenoxamine, and another arm for bisphenoxamine. She was in the arm of bisphenoxamine, and actually, over 1 year, the Tutostar does not improve. 13.6 and here 13.8, though the ejection fraction is still as it is nearly. Liver concentration decreased remarkably. Serum ferritin decreased remarkably as well. This patient then went to bisphenoxamine for 30 milligrams per kilogram, and when there was no improvement for this is Tutostar, she improved here after we changed actually the dosage from 30 milligram into 40 milligram per kilogram volume. Now the patient condition is much better. The heart failure remarkably improved. And if one of you are going to attend the patient doctor meeting tomorrow, you are going to see this patient after improvement, after she is receiving this drugs. And this is one of our patients. Actually, she is married and she has 2 children. This is give a very good hope for patients with thalassemia and for parents that good chelation and proper management of iron overload is the main issue in prevention of thalassemia complications. So good chelation is very important. Very, very important is to regularly monitoring the iron overload. Different organ function is a must for better outcome of the patient management. We should manage and to follow up our patients by Tutostar, LIC, should be regularly in order to have a better outcome and to interfere with this patient, increasing the dose of chelation before the complication of iron overload can occur. Cooperation of the hematologist with other specialists is very important actually, in order to prevent any complications of these patients and as well to have a better management of our patients and have a better outcome of our patients for their life and for even their quality of life. And thank you all for attending.
Thank you, Professor Ahmed, for your usual smart, illustrative, and presentable talk. Thank you very much. Now it's the time to open the discussion. Thank you. We have a lot of points to be discussed.
Please identify yourself.
Dr. Huda Rizala, head of the clinical hematology and hormone transplantation unit in Shamsi University. I'd like to ask Professor Ahmed, first I'd like to thank you for inviting us, the adult hematology unit for Shamsi University, to your conference that is distinguished, and we thank you for it. I'd like to ask you whether the stem cell transplantation changed, for the pediatrics, changed the outcome of the patients in Cairo.
Thank you for this question. Actually, bone marrow transplantation changed the outcome of this patient, but not every patient has got a donor, and this is very important. As well, most of our patients has got iron overload remarkably increased, have got hepatitis C, which may change the outcome of stem cell transplantation. But still, we have a lot of patients whom Dr. Hayaa Haddad did bone marrow transplantation, and they are very good, and they are enjoying their life now. Actually, it changes the life of patients who have a donor and who have a successful iron and bone marrow transplantation.
Thank you. I'm Marco Andreani from Rome, and thank you for your presentation. Actually, very nice, and I really enjoyed it. And thank you for inviting me here. I have a question for both of you. Since you are using different chelation treatment, I was wondering if you have any experience or any data related to Epsidin. We published a paper a few years ago in which we showed that a mutation in the Epsidin sequence was correlated to a worse iron chelation in those patients. So patients that carried this mutation had a worse probability to reduce the iron in the liver iron concentration. So since you're really very nicely observing these patients and the iron overload, it probably could be a very nice observation.
Thank you for the question. We know that patients with hereditary hemochromatosis and thalassemia actually load iron quite significantly, and we know that in those patients the hepcidin is suppressed, and therefore it's related to a hepcidin mutation, and that's just in the carrier population. We're currently doing a study, which is a very large multi-center study with Professor Pannell, where we're collecting DNA on all the thalassemia patients who've ever received an MRI scan, and those patients are going to be gene sequenced for hepcidin, DMT1, and all of those iron-promoting genes to see whether there are specific genes that are associated with a worsening clinical outcome. I think that will be We've currently recruited all the patients at the Whittington site. We're doing the UCLH patients now. We're going across the UK to collect all the patients up and down the UK who've ever had an MRI scan. We are going to be talking about 600 plus patients, and hopefully that will give the answer to your question in a very large population.
Actually, in Egypt, where we studied hepcidin patients, thalassemia major and thalassemia intermedia, and we find that hepcidin is decreased more in thalassemia intermedia. But for the gene controlling these, we are going in the future. We are going to study this.
No other questions?
I'm not a hematologist, but hematology and cardiology are twins. My name is Salwa Amran. Very old person here. I'd like to ask Dr. Amel if I heard it well. You said that thalassemia intermedia has worse effect on the heart, although the transfusion is less and the hemolysis is less. This is the first question. The second question is that as heart failure and cardiac problems are a major cause of death in thalassemias. We know that the systolic functions, the EF and the FS, are not markedly affected in thalassemia, and if it is affected, it is more due to the level of the hemoglobin rather than the precipitation of iron, and it is the diastolic function. You didn't try at all to give beta blockers for improving the diastolic functions in your patients?
For patients with thalassemia intermediate, actually there is many studies in this domain that there is discrepancy between the serum ferritin and the antiposition in the heart. And I have more than one patient who have serum ferritin is low, but they have remarkable affection of the heart, seeming that although they are not taking blood transfusion, but iron absorption is more. And I don't know whether maybe Farah can answer this question, that there is more predilection a more affinity of the heart to be affected with iron overload in thalassemia intermedia rather than in thalassemia major. Because we have patients with thalassemia major, and this is actually what we presented in ASH or in IHA with Dr. Benel, that we have in Egypt patients with 10,000 serum ferritin, and though their total star is normal and their ejection fraction is normal. So it may give us the background of the genetic factor on this. You can comment.
I think the question about what happens in thalassemia intermedia, I hope everyone can hear me, is quite an interesting one. We do know, and there is very good data to show that people with thalassemia intermedia get pulmonary hypertension. It's predominantly related to background lung damage because of red cell membranes causing a flip-flop effect, and then microembolyne thrombosis occurring in the lung, which then results in diastolic right heart failure followed by left heart failure, and typically presenting with pulmonary hypertension in these patients. We know that in thalassemia major patients who've been splenectomized and who have been chronically under-transfused, you have the same kind of pathology happening in that population. We do very rarely see, and this is relatively rare, that we see patients with thalassemia intermedia who have not been transfused or who have been intermittently, occasionally transfused, who do develop myocardial cirrhosis. I think what's really important is to remember that the cirrhosis that patients develop with thalassemia intermedia is predominantly gastrointestinal iron absorption. It's a different form of cirrhosis. It's predominantly within the hepatocytes. It's less focused on the macrophages, and I think it is only a matter of time. We're monitoring our patients now, but I think as we see iron overload in these patients, we know that by the time they're 40, they've got very severe iron loading with liver ions in the 40s and 50s types of ranges on R2 scans. And I think that over time, if you continue to monitor and do not intervene, you will see myocardial cirrhosis in these populations, even when they've never been transfused. But at the moment, the main patients who do get myocardial iron loading are thalassemia intermediate patients who are on irregular transfusion regimes. And I think one of the biggest problems in this population is the fact that we are completely misled by a discrepantly low ferritin. We do not initiate chelation therapy because a ferritin is 700 and we think, oh, it's nothing, and the liver iron may be 20 or 30 with a ferritin of 700. And we need to remember that imaging, and if you do not have access to imaging, liver biopsy are very, very important tests to confirm the degree of iron loading and actually then to think about intervening and doing iron chelation therapy in that population. Okay.
Thank you for this nice talk. I want to ask some questions first about the chelation therapy during pregnancy for pregnant ladies. Should we continue or stop it? Second question, is there any role for chelation therapy after bone marrow transplantation or stem cell transplantation? What is the optimal age to start chelation for patients? Thank you.
I'm going to be talking in a bit of detail tomorrow around endocrine problems in thalassemia patients, and I will be focusing a bit on the management during pregnancy of thalassemic ladies. All chelation therapy should stop, apart from desferrioxamine, 3 months prior to a woman becoming pregnant, particularly if it's a planned pregnancy. In patients who are very severely iron overloaded, you can safely use desferrioxamine because it's a very large molecule. It doesn't actually go across the placenta, so you can use desferrioxamine in severely iron-loaded patients in the 3rd trimester. But it's very important to use a relatively low dose and probably not to go above 30 milligrams per kilogram in those patients. We tend to only use a dose of about 20 to 25 milligrams per kilogram in our patients in London. So So that is the only chelation therapy that you can use in pregnant ladies. And then you can, of course, initiate chelation therapy as soon as the delivery happens. So at that point, you can go straight into iron chelation therapy with whichever agent, depending on if the lady's breastfeeding or not. So if she's breastfeeding, you can only use Desfrau. If she's not breastfeeding, you can go on to whatever they were on before. So that's the question around pregnancy. The other question was around post-bone marrow transplantation and iron chelation. We are being referred an increasing number of patients who are post-bone marrow transplantation, not just for thalassemia, but actually for acute myeloid leukemia, acute lymphoid leukemia, and all of these patients are very, very heavily iron overloaded on R2 scan imaging. The majority have got liver ions of above 15. None of them so far have got iron in the heart, and I think it's because of the short duration of transfusion that these patients have received. Most often it's about a year, maybe 2 years of transfusion. These patients should all be chelated down. I think there's good data to suggest that endocrinopathy risk is much higher if the patient's liver iron is high. We know that hepatomas, liver cancer and fibrosis are all there, and they're directly related to iron. So these patients should all be chelated, and if you cannot venisect them, which is obviously the cheapest, simplest, easiest thing to do, if you cannot do that, then you should be chelating these patients down to a safe liver iron, whatever the safe value is within your own practice. I hope that answers.
I think for bone marrow transplantation, as in the Professor Lucarelli Center, the biggest and worldwide known center for thalassemia bone marrow transplantation, they do every chelation before doing bone marrow transplantation. And if the patient is still iron overloaded after bone marrow transplantation, they do either by venesection or by iron chelation. So it can be used.
Kindly, Dr. Carlos. Dr. Carlos, I asked for discussion between reference to X and staging of fibrosis. Some patients improve and some patients make stationary and someone even worse. Is there a limiting factor for that observation?
Thank you for the question. I think that was just really, the study was mainly reviewing all the patients in the clinical trials. They had all required a liver biopsy at the beginning and at the end of 1 year, and that's from where that data comes. And even in the patients where the liver iron didn't get better, those patients, in the majority of those patients, the fibrosis score was either stable or improved. In a small number of patients, the fibrosis score got worse. Now, the question really is, who are those patients and why did it get worse? And I think the data doesn't show that answer, but it would be really interesting to know whether the patients that got worse actually had underlying other hepatitis, so non-C, DG, any of the other hepatitises, because we know that hep C patients couldn't enroll into that study, but they could have had hepatitis B, they could have had other hepatitis. There could be other confounding factors which explain the worsening in those patients.
Thank you. I'm interested also of the combination of therapy between diphylibron and diphylidrel. I think in Egypt we don't have that experience. It seems for me that you are giving one of them 5 days and then to stop treatment for 5 days and then start again with the other one 5 days. During the 5 days out therapy?
Yes.
Yes, you are making 5 days, 5 days, and 5 days.
Yes, that was actually just a metabolic study. It wasn't a clinical study. It wasn't looking at iron removal. It was basically aiming to measure the impact of individual chelators on iron excretion. And what Bob Brady showed in America was the fact that in those patients who were getting combination therapy with Desfrau and with XJ, the iron burden was very significantly, the total body iron excretion was actually very significantly increased. The reason the washouts were there wasn't for any other reason apart from the fact that he didn't want any previous chelator that was being taken affecting the results of the new study. So the patients were acting as their own controls, and that was the reason for the 5-day washouts between each block. But I think it is a really interesting combination therapy to use. I'm really looking forward to the results of the hyperion study because that's the combination study in myocardially iron overloaded patients. And I think that data has the potential to change clinical management for all myocardially iron overloaded patients.
I think we are on time by the minute. Thank you very much for the speakers and for the audience. And may I call on Professor Vedat Al-Ansari, Professor Dr. Faisal Hamouda to chair